Sorry, I was on mute. First case is a 73-year-old female who initially presented to her ophthalmologist due to visual decline in the right eye. On exam, she's neurologically intact except for an inferior field cut in the right eye, and left eye was 20 out of 20. Victor?
Hi.
Where do you think the lesion is?
Just going to go back to the diagram. It could right for one kind, so it's unilateral. It could be the occipital lobe.
What kind of field deficit do you get from the occipital lobe? Let's say it's a left occipital lobe infarct. You would have homonymous, which would be, you can see my mouse, right? It would be up and down like this, as opposed to inferior field cut.
More anterior in the pathway, perhaps distal to the chiasm.
Yeah. Okay. So where distal to the chiasm, you know, is the whole optic nerve involved? Like, so it's a little weird, right? So these are all the different types of visual deficits you can have. You're talking about having a lesion here at 3, right? But that would be complete monocular loss if there was a lesion involving the actual optic nerve. So in this case, we have a lesion in the orbit, not really involving the optic nerve itself, but pushing on the optic nerve. So she actually presented 5 years ago for this tumor. The image on the right is her initial scan before her first surgery in 2017. You can see it here, pushing on the optic nerve. That's probably why she had the inferior field cut, because it's coming on top of the nerve. And usually those are the fibers that are involved with the inferior field. She had 5 surgeries, one of which was super bloody. They couldn't get the whole thing out. They kept following it, and now it's grown to this size here. So what's on your differential?
How old is the patient?
73.
Someone with multiple occurrences of orbital mass. Differentials include solitary fibrous tumors. There's possibly angiomas, metastases can't be ruled out.
Okay, good. Yeah. Lymphoma, also potentially optic nerve meningioma is another one. Pretty good. So how would you approach this tumor?
For something like this, you could tackle it anteriorly. You could come from the front. You could maybe consider doing a cranial-orbital approach, expose the periorbitum, and then you could go in that way.
Mm-hmm. So yeah, so she had, the 5 previous surgeries were all anterior, done by ophthalmology. There was no neurosurgeon involved. So now that we're involved, we decided for a supraorbital approach. So this is kind of a diagram of the supraorbital approach. What are kind of the key anatomical landmarks that you need to be considering when you make this craniotomy here? Like, what are you worried about? One of them is actually in the picture.
Yeah, that's the frontalis.
No, frontalis comes up like this. So the supraorbital nerve here that comes out here. You have to be sure, not when you're making this cut, that you're not involving the supraorbital nerve. You have to move it over. What else are you concerned about when you're making a craniotomy in this area?
The frontal sinus.
Mm-hmm. Exactly. So they did a supraorbital approach, went down to periorbita, and were able to take out the tumor.
Oh, pathology shows on the left upper picture a low power view. You can see fat, you can see fibrous tissue, and you can see 2 or 3 blue cellular areas in the middle. On the right side, you see a higher power view, upper right, of the cellularity. So it's kind of haphazardly distributed. We don't certainly see samoma bodies or nuclear pseudo-inclusions or whorls of meningioma. This doesn't look like it. It's more like patternless infiltration of medium-sized nuclei with not too much of an atypia. The key thing here is that the meningothelial markers were negative, and most importantly, on the left lower corner, STAT6, a nuclear marker for solitary fibrous tumor / formerly called hemangiopericytoma, was strongly positive. So this really clinches the diagnosis of solitary fibrous tumor. And then, of course, grading. We look at the Ki-67. It's kind of medium, maybe 7-8%. And on the far right, you see PHH3, phosphohistone H3, which is a marker of mitotic figures. You only see one mitotic figure. So this turns out to be a lower grade solitary fibrous tumor. Orbit is a typical location for these things, so you have to consider this in your differential diagnosis. Higher grade of these lesions, of course, recur locally, and grade 3 practically acts like a sarcoma. Okay.
Perfect, yeah. So diagnosis, solitary fibrous tumor. Like Dr. Kultikin said, this is similar in histology to a hemangiopericytoma. It's a rare spindle cell neoplasm originating from the mesenchymal fibroblast-like cells. Presentation. So for our case, orbital lesions typically present with painless exophthalmos. Our patient had a field cut, but these can arise in any part of the body: the pleura, meninges, abdominal cavity, trunk, spine, extremities. So the presentation of these tumors are different depending on where exactly they're arising from in the body. So these are characterized by genomic inversion of 12q13 locus, resulting in the fusion of NAB and STAT6 genes. Treatment, like Dr. Kultikin said, usually gross total resection is curative for low-grade tumors. In this case, I think the ophthalmologists were having difficulty getting a gross total resection just because it was a very vascular lesion. There's no real consensus on adjuvant therapy, even for the higher grade lesions.
So Michael, I'd like to adjust something here. Your second line, which says similar in histology to hemangiopericytoma. Actually, now we accept both of these tumors as one and the same entity. And it is because of the genomic characteristic that you just described, okay? So solitary fibrous tumor and hemangiopericytoma is a continuum, and they are trying to do away with the hemangiopericytoma term and instead just adopt SFT and graded SFT grade 1, 2, 3, okay? So, and the STAT6 positivity essentially belies this change, that people realized that these were essentially molecularly the same tumor. Solitary fibrous tumor historically is a lower grade tumor, with a lot of collagen, and hemangiopericytoma is a higher cellularity tumor with so-called staghorn blood vessels, typically on histology. So they are histologically a little bit different, but molecularly identical. Okay.
Perfect. Thank you so much. Okay. Next case. Let's see what we have here. Big Nesh. Big Nesh? No. Eva?
Yeah.
Hey. So it's a 21-year-old male who presented with 2 weeks of worsening headache and nausea. On exam, he's neurologically intact. He was actually visiting his family in the area, but he just felt so sick and his headache was horrific. He went to the ER and got these scans. So tell me what you see here. Did we lose her? Eva?
Oh, can you hear me?
Now I can hear you.
Oh, sorry. Yeah, so it looks like they're on the CT, or on the MRI, there's a contrast enhancing lesion in the right and left cerebellum. And then with some edema, and then it looks like there may also be another lesion in probably like the ventricle right there, yeah.
What ventricle is here?
It looks like it's like maybe like the ambient system, or maybe third, I don't, or maybe like lateral or atrium. I mean, it's not really the atrium. I'm not really sure exactly. It's hard to see.
So it's really more like the pineal region here.
Oh, I see.
I probably should have included a sagittal cut for you. So yeah, multiple contrast enhancing lesions. What's concerning on like these two images here with someone with headache and nausea vomiting?
Oh, there's a concern for hydro, but the ventricles, I mean, they don't look too big.
Right.
I guess we'd have to see the sagittal to look to see if he has like obstructive hydro, but I mean, the fourth ventricle looks kind of like it's effaced right there.
Right.
Yeah.
Okay. So, sorry. So what's on your differential for this tumor?
So yeah, so there's multiple lesions at like the great white matter like junction, and so probably like Mets is the highest. There's also, yeah, I think Mets is the highest on the differential. Less likely to be like like a ependymoma or subependymoma, because you have these intraparenchymal lesions.
Mm-hmm. What about the age of the patient?
If it's 21.
What does that make you? He's got lesions here near the pineal gland, here. Does that make you think of anything in a young patient?
It'd be like VHL, hemangioblastoma.
No. So potentially here, I'll pull up the next slide. So you could have primary parenchymal tumors or germ cell tumors. Sometimes you can present with multiple lesions, and these young patients can have these germ cell tumors. So what do you want to do next for this patient?
Yeah, so I mean, we'd have to get diagnosis, and if we're concerned about like germ cell tumors, and we could send CSF, and then send like AFP, beta HCG, alphas, and then we'd have to get a diagnosis, so we can just take out the two like cerebellar lesions, because they'd be the easiest to access.
Okay, so how are you gonna be able to get CSF in this guy with early obstructive height? Yeah, you don't want to do that. But you can do serum levels for beta HCG and AFP. So you're on the right track, just not the lumbar puncture. Is there any other imaging you want? If we're, right now, I guess our primary working diagnosis is like a germ cell tumor. We want to rule that out, because if it's a germ cell tumor, then you can just treat radiation.
So wait, sorry, what was the question?
Is there any other imaging that you want in someone with multiple lesions in the brain.
Oh, like CT chest abdomen pelvis.
Yep. And then you could also get an MRI of the entire spine just to make sure there are no lesions there. And then one more thing, this looks like a metastatic lesion. If we're still concerned about a germ cell tumor, an ultrasound of the testes would also be a good idea, just to see if the primary tumor itself is there. So we did all that blood work. So both AFP and beta HCG were elevated. The MRI spine was negative. All the other imaging was negative. So with both AFP elevated and beta HCG elevated, what is your like primary working diagnosis at this point?
If AFP is elevated, then it's probably yolk sac tumor. Right.
And then, but a Buell says beta HCG that's very elevated. So both are super elevated.
So I guess Choreo
Huh?
has a beta HCG.
Correct. So it's weird, right? Both of these are elevated. But you're right. Yolk sac tumors and I guess choriocarcinomas would be at the top of your list with both of these elevated. And so since we don't have like a definitive diagnosis with any of this imaging, you would take out both lesions, one lesion, all three lesions. I can go back to the imaging if that helps.
I mean, I think you can just take out the cerebellar lesions because they seem the most accessible.
Do you need to take out both?
I mean, the right one's causing the most, it's the biggest and it's had the most edema, so you can take out that one, I guess.
Perfect. Yeah. So that's what they did. They did suboccipital craniotomy to take out that right cerebellar tumor for tissue diagnosis.
In this case, the slides I found out that were sent to Children's Hospital for, I don't know, maybe the patient was transferred there. I'm not sure. They wanted to see the slides. But I have the frozen section slides here. And on the left top, you see the intraoperative touch prep, which obviously has malignant cells with high nuclear cytoplasmic ratio. And on the right side, again, on frozen section, you see like in the center, a very cellular blue area, which shows at the bottom very atypical looking epithelioid cells. So my thinking is that this part actually shows, this is a frozen section, so it's a sample. And I think this part is the embryonal carcinoma part of the lesion. And then on the, again, top right picture on the lower corner, you see this more lighter mesenchymal area, which probably is part of the teratoma. So this was a mixed germ cell tumor with teratoma, yolk sac, embryonal carcinoma components. I don't have the report in front of me, but essentially malignant mixed germ cell tumor with these components. And of course, you should look at the mediastinum and the gonads for a primary. It would be unusual for a germ cell tumor or primary germ cell tumor of the CNS, to be this disseminated. Typically, you see more like a midline confined tumor, although you did have a pineal lesion here. Anyway, I'll let you discuss. That's the pathology.
Yeah. Perfect. Yeah. So it's mixed germ cell tumor, teratoma, embryonal carcinoma, and yolk sac tumor. So, Eva, that's why we saw that mixed picture of both high beta HCG and alpha fetoprotein. These really only account for 3% of primary brain tumors, which was weird in this case, as Dr. Kultaken was discussing, that there was no primary primary tumor outside of the CNS. All of his imaging was negative. There's a higher incidence in males peaks in the second decade of life, which is perfect for this case. He was 21. The prognosis for these are unfortunately poor because they're generally metastatic to the brain. Treatment would include cisplatin and etoposide. If you get complete resolution of these tumors from the chemotherapy alone, then you proceed to craniospinal radiation. But if you don't get complete resolution, then they have to switch to a different chemotherapy regimen. Yeah, that was pretty interesting. Okay. Third case, Suman. Suman? No. Is Adam on? Damien? Anyone? I guess Vignesh.
Hey, yeah, I'm here.
Hey. All right, so this is the third case. 59-year-old female who had 2 spontaneous episodes of a right temporal occipital bleed, both occurring in the same exact location, approximately 1 year apart. Workup so far had not shown any vascular pathology. On exam, she's neurologically intact. So angiogram was negative for AVM or anything like that. This is her imaging. Describe what you see.
So it looks like on the contrasted scan, there's like some slight contrast enhancement in that right temporal occipital area. And then on the let's see. And then on the other scan, it looks like I think a flare. There's like some flare hyperintensity there with some like mixed hyperintensity.
And then this is, SWI just showing the blood in that cavity. So what's on your differential with someone with recurrent bleeds, but no vascular pathology?
I guess my primary concern would be cavernoma in someone with recurrent bleeds, something that's angionegative, and has blood on the SWI.
Okay. You typically usually you'd see like a popcorn appearance here, and it'd be visible on the on the imaging, but that so far the imaging itself was negative, except for these little like small lesions here. Anything else on your differential? Kevin, that was good.
I guess I would guess. I mean, it could be some sort of like metastasis, like renal cell carcinoma, or something that's very bloody and and has and maybe like hemorrhage. GBM, I know it can be very vascular as well, but it typically would have more contrast enhancement on the contrasted MRI scan, but it could also present with recurrent bleeds.
Okay, and then another lymphoma could be one. And what about like non-tumor entities?
I guess
read my mind.
Yeah. You could I guess non-tumor wise, I guess if you're like looking at I guess like some sort of like distal aneurysm, like a mycotic aneurysm or something that may not necessarily show up on maybe too small to see on angiogram or on MRA, but could have these recurrent bleeds as well, or a small AVM or something maybe.
Mm-hmm. Okay, so differential lymphomas, sarcoid is another one. Vasculitis is something to keep on your differential. They're really the MRI with the contrast enhancing MRI. they reviewed it. It was after an angio. Neurology seemed to think that it wasn't any tumor in those enhancing areas. So I kind of led you a little astray there. But vasculitis or an angiopathy in someone with recurrent bleeds, those are things to keep in mind as well. So she went for a biopsy of the area to sort of figure out what the diagnosis is.
Well, let me ask if there was a history of, in this patient, a lobar intracerebral hematoma. What would you guys think? Nobody? Okay. So let me show the pathology and then you can reconsider. So on the left, there is a area on the left half of the picture that has vasculature and it looks like a small subacute infarcted area on the right lower side of the picture. You can see the vascular proliferation. But notice that there are 3 blood vessels here, blood vessel profiles with thickened pink walls. These are small parenchymal blood vessels. The walls have lost their smooth muscle cells. There's a pink homogeneous substance, filling the mural portion or the wall of these blood vessels. Next slide. So on the frozen section, again on the left top, I was able to see those better, and actually we did give them a diagnosis. You see these blood vessels, again, unusual homogeneous pink anuclear appearance of the blood vessels. Make a long story short, on the right upper picture, you can see the salmon-colored staining of these blood vessels with Congo red, a marker for amyloid. So this was amyloid angiopathy. The reason I asked about lobar hematoma was because amyloid angiopathy, among other things, does cause lobar hematomas, especially in the elderly. It's a typical situation. At the bottom, I did silver stains to see if there were amyloid plaques and neurofibrillary tangles, because this condition, amyloid angiopathy, frequently accompanies changes of Alzheimer's disease. And lo and behold, there were some plaques, as the silver stain shows, on both sides, these dark black looking spots. I couldn't find any tangles. Therefore, I could not diagnose Alzheimer's disease, but I am sure, sampling error may be playing a role here. Sometimes there is isolated amyloid angiopathy, but those are mostly familial amyloidosis cases. This case has a higher chance of, unfortunately, having an Alzheimer's disease background. That's it.
Perfect. So yeah, cerebral amyloid angiopathy. So just to go back to the initial presentation, she's pretty young to presenting for this kind of to have amyloid angiopathy. But basically, this is a form of angiopathy where the amyloid plaques are deposited into the small to medium blood vessels of the brain, weakening them, predisposing these patients to recurrent bleeds. They present that way. And then Vignesh, what would you say is the difference between hypertensive bleeds and these amyloid angiopathy bleeds in terms of their location?
The hypertensive bleeds are more in the deeper structures like the basal ganglion, the thalamus. The lobar bleed in this case is more unlike hypertensive bleeds. Amyloid angiopathy causes more lobar bleeds.
Yeah, you can still get hypertensive bleeds in the parenchyma. It's it's not as likely as the cerebellum or the basal ganglia, anything like that. In terms of people who get this, it's more common in patients with Alzheimer's. Dr. Voltaken was saying there are instances of inherited forms of this angiopathy. They're usually due to overproduction of the amyloid precursor proteins. Do you know what inherited sort of form would predispose you to either Alzheimer's or amyloid angiopathy, and why is that?
It's more common Down syndrome because of the repeat of chromosome 21, and I think amyloid's on chromosome 21 as well.
Yeah, the amyloid precursor protein, the APP, is on that chromosome. So they have 3, so they produce more of it, which is why they tend to present with Alzheimer's earlier. Unfortunately, there's no treatment for this disease. It's just symptomatic treatment of their bleeds. Next is case 4. Who do we have?
I feel bad. My phone wasn't allowing me to answer, so I can take this one for the third before.
All right, go for it.
32-year-old female, 15-year history of right ventricular lesion with increased headaches and size of lesion with the otherwise normal neurological exam. Just based off of this right there and that imaging, a few differentials pop up. There's a contrast non-enhancing, it seems, yet diffusion restricted lesion in like the right frame and like near the and that
this is diffusion. This is flare.
Oh, sorry, flare enhancing. Excuse me. Kind of like a hyper intense lesion, yet non-contrast enhancing lesion in the what looks like the right foramen of Monroe area, with a little bit of, I would say a slight ventricular megaly, right worse than left. It would make sense with kind of her symptoms of like increased headaches. There's also kind of flare. I don't know if it's maybe the cut, but some flare in like the occipital horn of the right lateral ventricle, right there as well.
Yeah, right. So her right ventricle is what?
The right ventricle. It seems like it's in like it's almost trapped.
Yeah.
Just based off of like how it's bowing out.
Exactly. So what's under differential for
differential for this type of lesion? So a ventricular mass kind of in this area. It doesn't look like a classic colloid cyst, but I'd put colloid cyst on the differential. Central neurocytoma on the differential. I'd also put maybe meningioma as well. You can have some subependymal tumors, though this is kind of an atypical lesion for that area. I think one of them, in the same line of like a subependymal tumor, if this patient has like a history of like tuberous sclerosis, perhaps this patient could also have like a subependymal giant cell astrocytoma. So that's by the super broad differential, but those are the things I would think of.
Perfect. Very, very thorough. Sorry, typo there. Central neurocytoma, not blastoma. Glioma can still be. No, you were right. Central neurocytoma. That's my typo. Meningioma can very unlikely to present there. They're usually in the body or the atrium of the ventricle, or glioma could potentially be there as well, but very good. So how would you approach this tumor?
Yeah, so for approach to this tumor, you can go kind of the transcranial using a tubular retractor system. I know we use a Vicor here pretty frequently. So that way you can use like a kind of a right-sided craniotomy to get into the ventricle and do that. You can also approach this transcallosal interventricular as well. But I would err on the side probably. I guess I've just seen more when I was at UMH, kind of the transcranial tubular retractor kind of system.
Okay, good, perfect. Yeah. So what would your like pre-op considerations be in terms of pushing you one way versus another? In terms of doing the interhemispheric, what are some things you look for on the scan?
Things that I would look for on the scan. I would want to. Well, I'd want to see like what kind of bridging veins exist in that approach, because you don't want to take any of those, particularly kind of like the middle, that middle third, the neurosagittal sinus. I also would be, I'd be very careful about the pericallosal arteries, and then also the A2s and the A2s as they come off. Just kind of determining where those are. Then,
Good.
yeah, those are the mainly vascular. My considerations would be for that approach.
Okay, and then what are the sort of like advantages and disadvantages in terms of, I guess, sort of what am I thinking of the surgical view between the two? Like, why is the interhemispheric approach advantageous over the Vicor in terms of what you can see, what you can't see?
I guess when we've had these discussions in conference or similar cases, the things that I took from those conversations where, if you have, you're able to get a lot of view of the entirety of the ventricular system, particularly with like larger lesions for things like blood control, like a blood loss control. Though that generally pretty bloodless type of procedure. Another thing would be the consideration for, well, you're also that's like, I guess, like the main thing I'd be thinking of is really just the surgical view.
The other thing that we had, I guess, discussed in conference was, with the interhemispheric, you have an easier time looking around the foramen of Monroe because the tumor isn't like purely in the lateral ventricle. Some of it goes down into the third ventricle through the foramen, and through the Vicor, it's a little harder at least to kind of reach around and get that view, but usually that's not an issue. So yeah, I mean, you touched on pretty much everything. The two different approaches for these. So for this case, they did the Vicor, and we're able to take the whole thing out without any issues.
Okay, so in the center picture, you see the classic pilocytic cells, pyloid cells with bipolar processes, very thin processes, hence the name pyloid. That means hair-like. And if you look at the nuclei, they look small and low grade. So on frozen section, this would be a low-grade astrocytoma, probably pilocytic. And on paraffin sections, you can see at the top that there's, on the left top, you can see that the right side is darker pink and the left side is lighter. So these are alternating light and dark background of typical background of pilocytic astrocytoma. On the right top, you see again the pilocytic cells stacking up and some multinucleated looking cells. These used to be called in the center top here, like pennies on a plate, typical appearance for pilocytic astrocytoma. On the left lower area, you see GFAP positivity with all, in all these cells, in tumor cells, with, if you're wondering what the GFAP negative areas are, those are blood vessels. So they don't stain, they should not stain. And they serve as a built-in negative control for the glial fibrillary acidic protein immunoassay. On the right side, at the bottom, you see the Ki-67 index is very low, around like 1%. So this is a pilocytic astrocytoma. Of course, we also rely on the absence of typical diffuse astrocytoma parameters such as retained ATRX, IDH negative, P53 negative, and we would send this for BRAF alterations, either BRAF fusion, a duplication fusion, or BRAF mutation, typically. So this is a pilocytic astrocytoma intraventricular example.
Perfect. Yep, pilocytic astrocytoma. So yeah, epidemiology, 75% occurring in the first 2 decades of life. It's the most common primary brain tumor of childhood, accounting for 15% of all pediatric brain tumors. It's associated with NF1. Sumed, patients with NF1, when they get pilocytic astrocytomas, what is the like a stereotypical location for those tumors? A hint, it's one of those on the slide.
I would say cerebral hemisphere.
Close. It's, the optic pathway, the one just above it. So yeah, optic pathway astrocytomas are typical in patients with NF1. But most of these tumors present in the cerebellum, especially in pediatric patients. In adults, it's more common to be in the cerebral hemisphere, less commonly in the spinal cord and/or the ventricular system. And then I included this, histology slide up here, just for those of us who are taking the board, just again to reiterate, these dark pink lines are the Rosenthal fibers, and that's stereotypical for a JPA as well. And then treatment is surgical resection. Sumed, for this case down here, do you have to take the whole cyst? Do you just have to take the enhancing nodule?
I think you definitely have to take the enhancing nodule. I would say you should try to get the whole cyst, but yeah, I would say yes.
So usually you don't have to go for the cyst. You just have to get the enhancing nodule in these cases. And then for optic nerve or hypothalamus lesions, usually it's just biopsy. If the lesion is in the optic nerve pre-chiasm, you just resect the affected nerve and you leave the chiasm spared. But if the chiasm is involved, it's usually just a biopsy. And then the 5 to 10 year survival, the prognosis is very good. Greater than 95% of these patients are living after 5 to 10 years. That's all I have.
I guess really quickly, with this case, is there something that would have pointed you towards pilocytic astrocytoma? That's the one thing I didn't include in my differential.
No, honestly, especially because, sorry, I'll share my screen again. If you go back to, the actual image, you'll see it really wasn't, usually these tumors are, if they're not cystic, they're contrast enhancing, which was weird in this case that this was not contrast enhancing. I think the initial running diagnosis for this case was, like you had mentioned, a colloid cyst, which is why she was being watched for 15 years. She was asymptomatic, nothing needed to be done. But once this tumor grew and started to obstruct her foramen marorum, then, our hand was forced and we had to take it out. But it was just interesting that it was, it was not a colloid cyst, it was a JPA, but nothing on the imaging specifically pointed to that really, except for the fact that this isn't a cyst. It's not a colloid cyst.
Gotcha. Thank you.
Mm-hmm.
Dr. Wang, you here? Yeah, I'm here. Oh, hold on. Do that.
Good morning, sir.
Are we starting early?
I guess they finished early, yes. Dr. Levy?
Yeah, no, that'd be
You guys want me to
great.
go
Thank
ahead,
you
or-
again, Mike.
Finish early.
Ignacio, you're running this, or?
No, you can share your screen, doctor.
Okay, great, perfect. I just wanted, sorry, I've got two computers running, so I want to make sure I don't have any echo in here. Can you see that, Ignacio?
Yes, we can.
Okay, volume's okay? Great. Sorry, I was up in the 7th floor. I thought we were having live, but I realized now that it was all just for M&M. So, all right, well, thanks for tuning in. Oh, sorry. Let's go up here. Thanks for tuning in. I'm just trying to take a look at who the participants are. So anyhow, okay, yeah, so thanks for letting me do this, Howard, for forcing me to put something together, because every time I have to do this, I try to come up with something new, and that turns out to be very helpful to me later for national speaking type arrangements. And I just want to say a shout out or a commentary to the residents and fellows. Like, I was talking to some of the spine guys, and I'm like, listen, you guys need to get grand rounds, because part of your training program is really learning how to do the public speaking. And I don't think there's an easier time than now, when there's like for those people who are Zoom shy, well, it's even harder to give a lecture, if you will, in front of a live audience. And please, sorry, it's a little dark in my office here. Please try to take advantage of that. Even if you give like a 20-minute talk, it's just a great opportunity. We try to give our fellows opportunities on a national stage. So I thought today I would talk about some of our forays into what I'm going to call ultra MIS spine surgery. And this is kind of an area that I think is actively being developed. We all know what MIS spine surgery is. We've come a long ways. 20 years now. When I was a fellow under Alan Levy, we did our first tubular discectomy in OR 27, and we were so happy about that and excited. And I've given hundreds and hundreds, if not 1,000 talks on MIS surgery. And this is a whole new talk. This is only the second time I've given this. I think James Badu is the only one that's seen this when I gave this at the BNI last week. So it's a new platform. So thank you for letting me share it with you. And also, please give me feedback if you think it's crazy or negative or things that you don't like, so that before I go on the big stage with people, I can get some criticism. So it's a two-way learning process. I'm learning from you guys. I also want to give a shout out that even though we provide disclosures, I really want to say that, I'm very fortunate to have been in this center for at least the last 14 and a half years, and to have learned from my mentors and people around me and people below me, in particular, Dr. Green, who established the current department as we see it in Alan Levy, and who's the chair, and as well as all the cranial people who supported me, like Roberto Harris and Doc Marcos. So here's the more important disclaimer, which is that if you think about this issue of how innovation occurs, and America is probably the most innovative environment we've ever had in the history of mankind, in geography and time, this concept, and people like to show Scott's parabola, which is kind of like this very negative approach, which is like new things come, people do it too much, and then it gets destroyed. Well, obviously that's not really the case. The case is that we're innovating because we are looking for better ways to do things. And this is from Stanford University. Everett Rogers was in the 1960s during the last great renaissance of science before the current one. And you see that people have to make a decision where they live. So as I speak to the 70 or 60 or so people that are on right now, I'm thinking about, well, there's people that are going to live in the red area, which is innovators, and people are going to be laggards, and you just got to be comfortable with where you are. So I'm going to try to show you stuff that I think is on the cutting edge, I think. And it's important, of course, to discuss this within context, right? Because one of the problems with the current society is everything's being taken out of context, because context is everything, right? If you don't understand the context, you don't understand the conversation. And there is an environmental context at play. And it's something like this. We are about to undergo a very, very significant issue in terms of pressure. It's already happened, right? And the idea is that everybody likes this idea of evolution. They think that evolution is this wonderful thing, but evolution is like neural pruning. It's especially cruel, because if there is evolution, it means there's also obsolescence. And if you're on the wrong side of that equation, that means that you're irrelevant, right? So this is a very important concept. People like to adhere to only one side of things. I tell everybody I'm on a scale of agreeable and disagreeable, I'm a -10 for agreeable and +10 on disagreeable. And people are like, that's horrible, you shouldn't be disagreeable. Well, the only progress that occurs is because of disagreeable people, because you have to be willing to buck trends. So be mindful of that. And of course, I'm talking mostly to the residents and medical students right now. And this is kind of a kitschy slide that I put together thinking about the evolution of spinal surgery. And we can look at this in the same way we look at the evolution of man. So you can take, these are Homo habilis and Homo erectus. You can think, well, early spine fusions down here in the evolutionary tree, very important. And then we get to instrumentation, which is obviously very important for us today, up to things like interbody fusion, which is an evolution to higher rates of arthrodesis and more elegant MIS type approaches. Posterolateral fusion may go this way, who knows, right? It's hard to tell. MIS interbody fusion probably is the way to go as current standard. If you had to say, well, what's the best way to get a spinal fusion? If you could do it interbody, that's probably the way to do it. Although there's lots of reasons to do posterolateral. I'm not suggesting we're at any particular time in evolution, but then you could say things like cortical fixation, maybe like this, maybe a blind end, right? Because cortical fixation is a great idea if you can't do MIS and you need to put some screws in, but we've seen how that tends to fail and tends to loosen. Doesn't mean there's no role, right? We all have about, I think Caucasians have like 2% Neanderthal DNA. So there's some role, there's some learning there, but think about the evolutionary tree and where you sit on this in terms of technique. Now, this shows it in actual practice. This is a paper from the Thomas Jefferson group, the orthopedic group, showing that if you look at the light gray and dark gray, you see that instrumented fusion, posterolateral fusion, is on the decline and interbody fusion's on the rise. And there's a lot of reasons for this, right? There's a lot of pressures that cause this to happen. It's not always that the thing that survives is the better thing. It's just better in the context of the environment that it lives in. And that's an important point because the environment will change. So, you know, we in healthcare, we sit here at University of Miami, I believe the largest academic spine center in North America, at least as it is historically described in the recent 20 years. And Dr. Green and Dr. Levy have built that. But this is a very concerning slide. If you're not familiar with economics, I strongly encourage you to learn a little bit about economics. This is a concept called Bombel's cost disease. And if you think about it, if you were to sort of put a cost, not a value, a cost on what we have today, like cars today, like, you know, the cars we drive today, and I don't even mean a Tesla, it could be a, you know, a Chevy, you know, I don't know any cheap cars, but I'm just thinking Honda Accord, okay? That car is super awesome. It's a great, great value. And you go back to the 1970s, I don't know if you've ever ridden in those cars where the seat belts, like you have to adjust them, and the safety, and you can't even, I mean, the steering is kitschy, the tires are horrible, suspension's no good. And you think about how much better the cars are today, not just in reliability, but safety, in terms of fuel economy, in terms of production abilities, and being within the Six Sigma Toyota model, which is, it's consistent. It's a consistent product, right? That's amazing. But then think about healthcare and college. So those are the two areas that lie out, two large markets that lie outside of Bombel's model, which is that the costs are only going up. And why is that? But the quality, I don't know, it's better, right? But it is certainly not impressing people out there in the economic realm. And this is an emblematic indicator of that. And I know it's not equivalent. You can't compare things like, you can't compare healthcare to Moore's law in terms of information, but this is the cost of computing for an iPad 2. Now you could go to Target today and buy an iPad for, you know, what, $100, $200. You could get a really nice one for $800. But if you move back in time, just a short period, the cost of that computing power goes into the billions and trillions. And I'm not saying that you're comparing the old computers. My dad was an engineer at Georgia Tech, and we used to actually call on the phone and then plug the phone into a modem, like the phone, and he would, you know, that sound. And that's how he taught me. And we had punch cards. He'd bring home punch cards, and we'd look at, the residents don't even know what a punch card is, right? Think of how that's changed. Now, I'm not saying healthcare is the same, but we need to be judged or we are being judged, we need to judge ourselves with an understanding that that is the context. So I've been kept awake at night for the last 20 years about this, which is the reason for MIS surgery, which is the drive to MIS, which is the existential threat. And people forget this, that doctors are so vulnerable. If you want to hurt doctors, it's very easy. You take them down 10% in salary, watch people scream, watch them go nuts. Lawyers, businessmen, they've accommodated for that. They've figured that out. Everybody knows what the doctors do, right? They get a salary. They're like, my salary will never go down. They buy the maximal house they can, the most expensive house they can. All of our fellows and residents do this. And then if they were to ever lose their job or have a salary reduction, they would be totally screwed. Okay, that is not a very robust system for survival at all. It's not even close, right? So when this happens, and I'm not saying it's gonna happen, but the pressures are coming, right? Think about how we do this in spine surgery, and in cranial surgery it's different, right? Because a lot of people here are cranial. Maybe there's no cases for you to treat. Maybe the GBM vaccine arrives, or the pituitary adenoma vaccine arrives, and you lose 15% of your case volume. Right? Or maybe there's hope for the future that, the functional neurosurgeons are going to come up with new procedures for us to do, or maybe those procedures are going to be done by neurologists. Wow, think about that for a second. You've invested your whole life into this. So I'm kept awake at night by this kind of stuff because I'm a very disagreeable, pessimistic person, which is the dinosaurs thought they were fine until the diarrhea or the asteroid or the ice age, whatever it is, we don't even know yet, right? Or the meteor that hit and blew all the bits into the sky, and there's evidence of that, and they're all gone essentially, right? You got alligators, we have some sea turtles, they're gone, they're off the face of the planet, right? So think about what we do, and coronavirus is an example. That coronavirus is like a 0.001. I'm not minimizing the effect of coronavirus, but 0.0001% of something like that. It's not even close. If coronavirus was like Ebola and we had an 80% death rate, that would be a little closer to what I'm talking about. So it's not hard for us to get tweaked and wiped out. And if you look at other surgical fields, you will see that had happened, for example, to cardiac surgery. They essentially were wiped out. Now they're there to back up the cardiologists, right? So it's a very, very scary thing when you think about it that way. So what am I thinking about? So maybe you don't agree with me, maybe you've already tuned out. It doesn't really matter. It's at your own peril, right? But I'm thinking about, how do we get smaller? So think of me like I'm going to be that small furry animal, right? That little mammal, right? That's hiding, right? Maybe eating the eggs of dinosaurs. But here yet in the background, backdrop, you see T-Rex. T-Rex is stomping around, right? We know a lot of T-Rexes. Those are the people that basically take every human being, they take them to surgery for spine, and they do the maximal whack, the maximal RVUs, right? Because they think that this party will go on forever. And that might be okay. That might be reasonable to say, okay, well, it's like in the Matrix, right? The guy that turns in Neo, the turncoat, the traitor's individual says, well, I'll get mine first, right? I'm going to get mine first. And then, you guys can suffer on the back end. I don't believe in that. I believe that I'm a doctor. The idea is to try to do things better. Okay. So let me take you on this journey a little bit. And this, by the way, this is my personal journey. I'm not saying I'm doing things right, but we're attempting to do what we can in a very, very difficult environment. Okay, so enter the MIS TLIF. So, I was the third person on the West Coast of the US to do MIS TLIF. This was after fellowship when Alan had trained me how to use the tubes. And then we moved on forward, Larry Koo and I and Sylvan Palmer working on this stuff really early, right? And it has been widely adopted. There's all kinds of TLIFs. There's all kinds of MIS TLIFs. It's a workhorse procedure. It's widely accepted. And it's become something that's relatively straightforward to do for neurosurgeons because we know how to drill and do microsurgery. So you could do a decompression, cage placement, pedicle screws. Great, okay? Now, why do it MIS? Why not do open TLIF, right? Well, because you're getting some advantage with less pain, less blood loss, less complications. So this is an example. This is Kevin Foley's meta-analysis. You can see here a forest plot showing if you talk about pain after surgery, it goes to the left, which favors MIS. So if you're not familiar with forest plots, you should be. The left side is favoring MIS, the right side is favoring open. And this is a compendium of papers of higher quality literature, if you will. If you talk about things like earlier normalization of life, this is a lot of this work was done at Vanderbilt by Matt McGirt's group. It shows, of course, when you do the MIS procedures, people get back to normal faster, okay? When you talk about things like infections, we published this data off the Premier database, which is hundreds of thousands of patients, showing that there's less infection with MIS. Of course, that makes sense. You're exposing less of the body. There's less seroma formation. There's less of all this stuff. And that's pretty clear cut. CSF leakage, okay? It shouldn't happen, right, with MIS. It really shouldn't, right? But Similarly, you look at the forest plot, of course, you're exposing less of the dura. You're not opening as much. There's less geography just by chance that you're going to hurt the dura. So there's less CSF leak. This all makes sense. And I think we can all agree that the outcomes are relatively similar. And if you think about narcotic consumption similarly, right, this is an important thing, right? You think about the area between these two curves in terms of these are PROMs, patient-reported outcome measures, ODI, VAS, visual analog score, and the difference between MIS and open, in terms of the VAS every day or every week or every month, means something because it's less narcotic consumption. And why does that matter to us? Well, it matters to us a lot because, it allows people to get back to a normal life. They have less side effects from that, right? And we are going through an opioid pandemic, right? There's over 100,000 Americans dying of opiate overdoses every year, right? So we approached this from a number of perspectives, and one of them was ERAS. And I really have to give a shout out to Karthik Madhavan. Karthik came to me in 2012, and he said, Dr. Wang, you got to look at this ERAS thing. I'm like, ERAS is how medical students apply for residency. He goes, no, you don't get it. He goes, this ERAS stuff is big. And Karthik helped me launch the first successful ERAS program in the world in spine, right? And I say that without any reservation because we are now the representatives of USA ERAS spine as a body. So ERAS is this, and everybody's heard of ERAS. Now, we used to get up, and I remember Karthik had organized the first ERAS meeting at NAS, and I got up in front of 2,000 people, doctors, and I said, who knows about ERAS? And not a single person could raise their hand. Now, everybody's talking about ERAS. The nurses are talking about ERAS. Everybody's like, the administrators asked me to put together ERAS, right? So I'm not going to spend a lot of time on this because we could talk for many, many days about ERAS. But the idea is that it's a patient-focused, it's a team approach, it's a surgical journey, you're fast-tracking. I know that Mike Ivan, I think, and Rick Komatar are now doing cranial ERAS. We had a supplement in neurosurgical focus on ERAS 2 years ago. Damian Brusco has been integral in that when he was a medical student here. Now he's a resident PGY2. And it's most importantly, it's iterative improvement. So it's not a randomized prospective trial. What you do is it's a quality improvement program. So basically, you take a system like spinal fusion, say, we're going to change something. We're going to change the narcotic regimen. And then you observe it and you see what happened and you try to tweak it and then you iterate. So it's like keeping the good stuff, leaving out the bad stuff. So it's highly evolutionary in its perspective, right? This is colorectal ERAS. Again, I can give you a 3-hour talk on ERAS. I'm not going to do that, right? Go look it up. If you want to hear that talk someday, it's online for me, I'm sure somewhere in terms of what you can get. So I want to get back to what most surgeons care about, which is surgery, right? So in the process of going through ERAS and the passage of the Affordable Care Act, and in the wake of the last big recession, we started to really get serious about thinking about MIS, not just as a technique or a way to advertise or market as some people do, or not just a way to do something fancy, but how to really do something different. And we had to embrace new technology, right? There's no other way around this, right? So you have to ask yourself an important question. Because in the first iteration of the modern MIS realm, that was 2001, the idea was that the tube was MIS, that if you used a tubular retractor, and at the time you only had metrics tubes, that was the definition of MIS. So we started publishing all these papers, and everybody did, like spinal cord stimulator placement through a tube, MIS, spinal cord stimulator removal through a tube, MIS. And it got kind of silly, and Larry Koo would say, like, it basically became, look what I did through the tube, Mom, right? Like, very impressive, right? But if you think about this, what do you really mean by a tube? Like, what size tube are people actually using when they do a surgery? Is it a 14 millimeter tube or a 28 millimeter tube? Is it a 2 millimeter tube? Is it a 70 millimeter tube in terms of diameter, right? What is the size of the tube? And Greg Basil actually published a very nice paper that talked about this, which is about what does the size matter? Of course, size matters, right? So here's an example. If you took a 24 millimeter tube, which is smaller than the typical MIS TLIF tube, and the average actually is 28, and you took a 16 millimeter tube. When we started on this journey, when I said we did the first MIS PLIFs, they weren't even TLIFs, they were bilateral 14 and 16 millimeter tubes, okay, for fusion, right? So that was back in 2002. So think about the area tissue displaced. So the area, meaning if you just look down that tube, you're looking at the area. It's very simple calculation, right? We're all smart. We all took calculus. You don't even need that. You need geometry for this. So look at the difference in terms of the square centimeters. If you look at going down an 8 centimeter tube, here's the volume of tissue displacement. So that is a 3.2x on volume of tissue, just between 16 and 24 millimeters. Now, does that matter? Now, there was a time when we were measuring CPKs, not heart CPKs, but muscle CPKs, trying to measure strength of rectus spinae function. You can go really deep with this in terms of what that means and how you measure it. Those are great research projects. People love to do stuff like that. But the bottom line is that we can say that the stuff you go through kind of does matter a little bit. Now, at the same time, I was traveling the world and seeing other people do surgeries. And I arrived at traveling to mainland China and Taiwan and Korea and Japan quite frequently, because obviously I'm Asian American. And this is a picture that should get your attention. This is the JOIMAX users meeting, okay? 1,000 Chinese orthopedic surgeons in attendance. These are users. These are not like, oh yeah, let's get our chief residents, Jason Leonakis, take them to a course. There was a JOIMAX course last week. No, these are users. These are people like me who have the device, the towers, and they are using it every day. And when you go to China, and I know China is bigger than America. China is 1.3 billion people. So China is about 3 or 4 times as big as us, but it's not 3,000 times bigger than America, right? So it's a little bigger, right? Every major hospital in China has 1 or 2 or 3 or 4 or 5 orthopedic spine surgeons that only do endoscopy, okay? They don't do ACDFs. They don't do PLIFs. They don't do deformity. They don't do arthroplasty. They do 7 or 8 endoscopic surgeries a day, and the Chinese surgeons work 7 days a week. So you guys think you got it hard? They work every Saturday. They work every Sunday. They work every Monday through Friday, not just because of communism, because that's what's required. So they do like 60 surgeries a week, right? And they're doing it all the time. And when you see that, you're like, wait a minute. You know, I get it that a lot of people listening are like, well, endoscopic is like, that's like crazy stuff they do in surgery centers. How is it possible that 1,000, it's actually 2,000 surgeons, because there's Wolf and there's, it's funny, right? They want to, don't use product names. Well, there's only so many endoscopes, okay? So Wolf, Stores, Spine Endos, Eloquence, there's only a couple companies. They all have users in China. So how is it possible that, let's just say 2,000 people in China that dedicate their lives and do 60 surgeries a week are wrong? They're just all crazy, right? So I started to look deeper into this, and the idea is like, can you do this stuff? Can you work through these little tubes, 6 millimeters? Can you get surgery done? Can you actually achieve something? It's not an open surgery. I tell all my patients, it's like, it's not going to be the same, and there's negatives and positives. I'm not saying this just replaces the open surgery. I'm saying that this is a different way of doing an operation. So if you think about it, by rotating the endoscope, even though it's only 6 millimeters, you get to see around, right? Because it's angled. So it's not like a pituitary. It's not equivalent. First of all, you're working underwater. Pituitary's in the air. Second, it's angled, right? And so when you think about this, and you're working in a potential space, you're not working in a cavity, right? So you can look and you can magnify that view as you go further and further out, and you can rotate that endoscope in the other direction, giving you a different directionality to look at, right? So that's powerful because you can actually see about 2 centimeters around you if you have to. And Christoph Hofstetter, one of our former fellows, helped. He basically wrote this book. I mean, I did very little work on it. He was the one who wrote it. You can get a copy of this if you want, and it shows you all the techniques of endoscopy. And then we started to get smart. So everybody's heard of the one triangle we have in spine. I know in cranial, Jacques Morco's probably on. You have like 80 triangles in the brain. There's probably a Morco's triangle somewhere, right? We only have one triangle in spine. That's Camden's triangle, right? But it's actually not a triangle. It's a prism. And Luke Toomey Allen at the Barrow Neurological and I spent a lot of time thinking about this and exercising our minds, saying, what are we really doing here? We're looking at a 3-dimensional space, which is obviously not a triangle, right? And you can look, and I'm sorry, some of you have Zoom on the right, so you won't see this is the new aspect ratio of PowerPoint. It's wider, it's like a wide screen. So there's papers there on the right that we publish. Again, I'm not gonna sit here and tell you about all the papers I've written. I think that's boring. It's 8 in the morning, everybody wants to get to surgery. But the idea that you're working through a prism changes your view of how you see the geometry of everything around you, because it is 3-dimensional anatomy. And there's different approaches through Camden's triangle, and we're focused mainly on the transforaminal approach. We published this data. Greg Basil here again, right? Technical considerations in world neurosurgery. Look it up. These are different approaches: 1, 2, 3, and 3A, B, and C. And the idea is there are different approaches into the triangle that allow you to exercise different options with safety. And this kind of shows the open surgery, right? So in open surgery, the medial border of Camden's triangle, if you will, or prism, is the thecal sac. So if you want to retract the thecal sac more medial, this is how you do a PLIF or TLIF, you just retract it, right? So you make the triangle bigger and bigger and bigger. If you do an MIS approach, well, really it's how much facet you remove. So if you take the lateral facet, right, and you start to resect it going medially, you can enlarge that triangle up until the nerve root, and then you can retract the root too. But usually people are not trying to do a lot of root retraction in true MIS surgery. But when you work perc endo or percutaneous or endoscopic, you're not going to remove much bone. So you're basically confined by the medial wall being the facet joint, the lateral facet joint, or in this particular case, the superior articular process, right? So the SAP is your medial border, and there's different approaches to it, different angles through that endoscopic approach. And again, we can spend a whole hour talking about endoscopic approaches because the Koreans will sit there and tell you about the 8 kinds of disc herniation and which ones are easy to get and which ones are hard to get. So you can go really, really deep into these caverns and dive deep to get smart about it. We just don't have time for that. So this is an endoscopic 1A axis, which is really an attempt to try to get to the centrum of the disc. This is how you do a discogram, or how we do our endoscopic or awake spinal fusion. Right? So this is a 1B axis. This is coming down sort of from cranial to caudal, gives you great access to the neuroforamen safely and gets you to the far lateral disc herniations. And this is a 1C axis, which is sort of a more dorsal approach that allows you to decompress and get central stenosis from the transforaminal approach. And this is something Christoph Hostetter loves to do if he uses a transforaminal approach. So we have for a long time known, at least when I say we, I'm talking about me here and my colleagues here at University of Miami, that doing endoscopic surgery is great, and you can go learn from people who are much better at it than me, but we always view this as a bridge. So the bridge is to bigger surgeries. How do we do the bigger, badder surgeries to try to get in terms of a big surgery smaller, right? And so we want to go to MIS fusion. So this is the beginning of what we were doing. This is, I called it ERAS, but I know now this is not really ERAS. ERAS is really a program that can be generalized across countries and continents and hospitals, right? But here we're really talking about technically how we do the awake, endoscopic, percutaneous, or ERAS fusion, which is the endoscope, the awake anesthesia, percutaneous fixation, long-acting sodium channel blockers, the expandable interbodies, and infuse, which is off-label. This is, I don't think this is a CME event, so it doesn't matter, but infuse used in this manner is off-label. So this is an example, 65 minutes of surgery, 70 cc's of blood loss, patients in the hospital less than a day. And you can do this outpatient, and everybody knows here that we're not running a surgery center. We're not making the passive income off that. That's not the goal here. This is not a financially driven project. This is a project to overcome the existential threat to us, which is major. So this is the first case I ever did. This is the former dean of FAU Business School, so it's not a rat lab. And so you can see I'm talking to him, and Joanna Gernsback is here in the background with her orange is her favorite color, which is actually the least favorite color of any main colors, which is interesting. Little tidbit about Joanna. And so here we're looking through the endoscope, and we're taking out the disc, and we can see the exiting nerve root there. It's at about 11 o'clock, and the fat around it. You can actually see a lot, right? We're working underwater, so this is different than, again, people say, well, it's like endoscopic pituitaries. It's not like endoscopic third ventriculostomy either, because that's underwater, but you're working inside a cavern, usually a huge cavern because of the hydrocephalus, right? You're working in a potential space. There's no space created by God for us to be there. You're working inside of solids and liquids. So this is an important point. So now we're going to brush the disc and get it ready for fusion. Many of you have seen this. This is the first case we ever did, so I recorded it, and it's been a journey with this. So this is a surgery that is quite different, and I get it that people will have a surgery center and they'll have their own tricks, and they'll never tell you what they are because they're making a lot of money, right? So what they're doing is unilateral screws, slapping a fentanyl patch on at the beginning of surgery, et cetera, sending the patient to a hotel with a nurse, right? Because they're going to still do better doing that than with inpatient financially. That's not the game here. The game here is to try to make a surgery that it doesn't matter how sick the patient is, they could still get through this operation. So that's the kind of thing we're doing. And so this is a patient, not everybody's like this, the residents don't, not everybody can do this. But again, if I let you inject the Exparel, you're probably injecting in the wrong place, although Roberto Perez Roman and Joel Martin did a great job yesterday. So here's a patient right after surgery, an hour after surgery, walking around with a 1-level fusion, right? Minimal tissue disruption. And we published on this, right? So I don't want to belabor the point. You can look up the papers and whatnot. This is our sedation protocol. Thais, who was one of the fantastic residents, helped put this together. Jay Grossman, as you guys know, is the guy who did the initial foray into this. And Jay really helped me a lot because he had the courage to not be scared. And now people are like, oh yeah, it's like, we'll finish our first surgery before anybody else cuts skin in the hospital. And that's really powerful when you think about it. It's not about rushing in time. It's about understanding where we live in the world of Bommel's cost disease. So why do this, right? People are like, well, I don't like that. I can't play, the loud rap music in the OR if the patient's not totally asleep. Well, I mean, this is the most sensitive neuromonitoring, right? And there's effects on cognition and physiologic derangements and all these other things that, let me show you what that is. Here's a patient, here's a dentist that I'm gonna operate on. She's giving me the thumbs up, we're ready to roll. The Wall Street Journal published on this. Patients are actually aware now that when they go through a surgery, especially prone spine surgery, there is risk to their brain. And I ask patients, and I see it every day, that when I do a surgery, a couple hours long in prone position, they have brain fog for weeks or months sometimes, right? So here's an 86-year-old with an EF of 11%. Okay, now, I don't know what you guys know about medicine now, because everybody's truncated in their training, right? You don't do an internship in general surgery, but an EF of 11% is a no-go zone, right? That means that person just needs to live with their problem. So this patient has a grade 2 spondy, EF of 11%, we're gonna do surgery. There's pacer pads on the patient. Now, a cautionary note, what I'm not suggesting is we operate on everybody. That is absolutely the opposite. What I'm saying is that we're not incentivized to operate on people who are sick or diseased or poor or morally or socially or economically or societally dispossessed, right? What I'm saying is that when someone needs a surgery, a lot of surgeons go, no, thank you. I'm busy. I'm making lots of money. I don't need to do your surgery. So go take a hike. That's what they tell people. What I'm saying is we're treating humans. And if you do that, you're playing God. Now, I'm not saying that you're not going to have better outcomes. I'm saying you're saying to another human being, and we're in the democracy, right? So every human's worth the same. I don't care. Go live your life, right? Now, what would you do if that was you or your mother or your wife or your son, right? What would you think about that? Now you know why we're judged harshly. So this patient's having, as you see, grade 2 spondy corrected percutaneously, pacer pads on, did fine with the surgery, right? Physiologic derangements. Cardiac. When I was at Stanford in medical school, I took anesthesia as a rotation because I wanted to get good at procedures and intubating. And the anesthesiologist there told me, being intubated is like having an elephant step on your chest. He goes, the stress of that is enormous. And it's like they say, anesthesiologists are like pilots. It's the takeoff and landing. It's not the flying that's dangerous. It's the takeoff and landing. And so the cardiac stress is enormous. Who hasn't seen this? Right main stem intubations, all these problems with hitting the vocal cords, knocking teeth out, all these pulmonary issues, right? Temperature regulation. There's a term that we don't use a lot in neurosurgery called homeostasis, right? Not hemostasis, homeostasis. We forget about that. The human body auto-regulates. Jacques Marcos knows this. Blood supply, how do we regulate? I mean, we auto-regulate our brain blood flow. It's when we put people under anesthesia that we get inadequate blood flow to the brain, and then all of a sudden the patient wakes up with a stroke, right? With hypoperfusion syndrome, right? Catheterization. How many patients, male patients especially, have to stay in the hospital because a catheter was put in, right? Now they gotta stay in 3 days. What does that cost, right? And I love this slide. This is an A-line out of OR 28 at Jackson. Patient was having surgery with me. A-line was put in, dissected the entire arm. And this lady still sees me. She still comes to me and says, look at my arm, Dr. Wang. This is the big scar. Look at my back. And she had a big surgery. It's not that bad. I mean, her surgery was canceled. She had to delay surgery for 3 months while plastic surgery dealt with her arm, right? It's not benign, right? It's nothing we do is benign, right? And you can expand the population of people you treat. This is a paper out of China showing that MIS-TLIF, the outcomes are just as good with old people. And Paul Park from University of Michigan showed that similarly. How about this? Look at this. This is from Dan Resnick, right? You like this? They don't want the panis to sit on the floor or have too much pressure, so they just stacked up a bunch of stools underneath it. Look, we don't have a lot of this in Miami, but I can tell you it doesn't matter the size of the patient. Here's an example. This is an executive from a major healthcare company who came from far away to have surgery, BMI of 53.12. Again, I'm not suggesting that we want to operate on people that are overweight, but let me ask the audience, and it's sad that we're not together. How many Americans do you think are out there today? There's 340 million Americans that want to be fat in our society. Like, just, are you happy being fat? Do you prefer that? Like, now, I'm not saying that they shouldn't try to lose weight. I'm just saying, you go tell someone who can't walk, I want you to lose 200 pounds. I could do that similarly to you guys. I could say, hey, I want you to stop drinking alcohol. I want you to stop, staying up late at night. I want you to stop being a jerk to other people. I want you to stop, speeding. It's easy to judge other people until the shoe's on the other foot, right? So this guy's a high level exec, right? In lateral position, 425 pounds, without general anesthesia. You can see that there, right? You don't see any tubes going into his head or face. Think about what that means in terms of the power of your ability to treat people, because you're not opening them up. It doesn't matter how deep it is, as long as it's under 12 inches, right? You can work inside them because you're working with a scope, just like in a pituitary. Do you guys care how big someone's nose is or how deep the sinuses are? You don't care because it doesn't matter to you, right? And this is the patient pre and post-op doing very well. Here's a case, right? This is a lady who came from where my son goes to school. One of my sons goes to school, Madison, Wisconsin. And the patient had gone to a very reputable, one of the most famous spine surgeons out there, and had a laminectomy. Super simple, right? No problem, right? Except there's a CSF leak. Well, no big deal, right? CSF leak ends up resulting in a subdural hematoma. She loses vision in one eye. She's hemiparetic, plegic temporarily, and is in ICU for 31 days, okay, from a laminectomy, okay? Spine's tough. People joke about bread. There's no bread and butter spine. This is bread and butter. If this is your bread and butter, you got an ICU full of comatose people. So the patient ends up having post-laminectomy instability and comes and sees me and says to me, and her blindness is better in the one eye and she can walk now. And she's weak in one side, but she's not plegic anymore. And she says, Dr. Wayne, can you help me? I can't live with this anymore. Now, who is going to go and deal with this? Now, Timur will probably say, I'll do 2-level OLIF, right? That's good. I like that, right? But I want to do as small surgery as possible. So I'm going to do awake endoscopic fusion, 2 levels, right? ODI goes from 64 to 22, right? She's in the hospital for 1 day, leaves. Here's another example, okay? Because I know Timur's a master of going anteriorly, and that's a very important skill set, which I'll come back to later. This lady comes in, obese, has a flip and stenosis. So I'm like, well, let's do a talar retractor MIST lift. So we do that, right? And you can see how bad she is, right? And here's a talar retractor, and we go and we do the decompression unilaterally and a discectomy. And this was actually with Seth Hayes, right? And I love Seth. Seth's a great surgeon. And he takes a bite deep in the disc, and boom, this rush of blood comes, right? And we're like, oh, okay, well. So we pack it off with gel foam powder. And then we're like, okay, well, bleeding stopped. Let's keep going. So he puts in the paddle distractors to start to prepare the disc space further. And when he does it, he turns the thing vertical, which is what you're supposed to do, opening the disc space, right? Boom. Another rush of blood. And then the patient goes into asystole. Now, I don't know if there's any anesthesiologist listening. This is when it matters, right? Like everybody's like, oh yeah, CRNAs can do everything. But we had an amazing CRNA who has left us to go to UC San Diego named Gil Soto, right? And I'm like, holy fucking shit. He goes, you got air embolism. I'm like, really? He goes, fill the wound with water, right? That's what you do, air embolism, right? So we do that, right? And sure enough, we stopped the bleeding quickly, right? Her systolic pressure went from 135 to 95, sat dropped to 92, and she flatlines for 10 seconds, right? And you see the AA gradient 110 millimeters. Marty Weiss, my old chairman who trained me at USC, said the neurosurgeon's the only primary care doctor. All that stuff you learned, the science, the physics, the math, the ICU care, remember that stuff. That makes you better, right? So the AA gradient, huge, right? Air embolism, right? So what do you think about that? So what do? We close her up. Only she's got a slip now, and we've destabilized her even more. So we sew it up. She does fine. I talk to her son, and she goes home. Let me ask you, what are you going to do with this now? So now you've got a slip like this. You're going to just let her try to live like this? She goes, my leg pain's better, but my back pain's worse, right? BMI is 37, right? You going to go in front? Does that sound reasonable now? I mean, I don't know. I've never done this kind of surgery anteriorly on someone who had air embolism. Probably safe. I don't know. Who knows, right? So what are we going to do? We're going to do surgery underwater, right? And here we are fixing her, and she's this lady's 7 years out or something like that. It's early experience with wake TLIF. And the outcomes are good. Like it's not perfect, but if people say, well, you're going to get non-union. So you can see the nerve roots, you can decompress, you can clean the end plates thoroughly. You can see the cartilaginous end plates have been removed. You see the bony end plate there, right? And you can get indirect decompression. Here's an example, pre and post-op MRIs showing that the ligament is resolved from stretching as well as the fusion, and it looks good, right? And we looked at our cases very seriously. Residents and fellows who come to my clinic know that I follow my patients forever if they need to be followed. They never are completely discharged. And the indications are important, right? So indications are the key. As Dr. Harris would always tell you, if the indications are good, the surgery result tends to be good. The indications are more important than the technique. So, these are good indications: spondy, recurrent disc herniation, top-down stenosis, and scoliosis, right? And we did our 350th case yesterday. So we have some experience. We have some knowledge about how this works, but we have problems, right? So DRG, the dorsal root ganglion, that is the biggest structure at risk, right? So I harp on this, and I know that a bunch of guys went to the JoyMax course last week in Seattle. I'm just going to tell you, I'm going to say it one more time, maybe the last time you hear it. Don't believe everything people tell you. Be careful, right? Because the DRG is a sensitive structure. And if you hurt the DRG, you have made an enemy for life, okay? So be careful when you watch our former fellows showing Instagram photos of how much disc they remove. And I'm going to tell you right now, and everybody knows this, I'm kind of chicken shit, okay? I know we're probably being recorded. I'll say it, I'm chicken shit, right? This is a real danger, okay? This is the only danger, really, of doing this surgery. So be careful about that. Be careful about, you're like, how many centimeters you start from midline? Like, you're not getting this. It's like asking Jacques Morcos, right? How many stitches you got to throw in that ECIC bypass? It's like, you do the correct number for this case, and it may change depending on what happens, right? It's dumb. Don't be so stupid. It is not cookie cutter like that, right? So the DRG is the main thing. We have to convert some people to general. That's fine. We put a stitch in, flip them over, we keep going, right? Some people need a formal decompression. We do the hard work, the fusion, the inner body, all that. And if they need a laminotomy, a couple people have done that. It's not even that they always needed it, but we're like, well, your symptoms aren't better enough. And not everybody gets better with surgery, right? In our early experience, we had early cage extrusions, right? And I've explained to the fellows how we prevent that. We haven't seen that in the last 200 cases, right? Delayed non-union, we've only had 2 cases. Only one's been fixed, right? We did that with lateral approach. Next time I'll send them to Tumor. No real wound infections. We had some early problems, which I'll show you here, that were related to cage extrusion. So before I get to the problems, which I will, there's the economics and efficiencies. And I know Greg Basil loves this stuff because he loves to talk about the dollar cost averaging of your work and all this stuff, right? So this is an old slide of mine. It's been copied a lot. I put this together when I was a fellow under Alan. This is the cost of surgery. The area under the curve is real. That area can be measured. That is the main reason why people are afraid of us. That cost, we don't even pay attention to. That's why we have PAs, nurse practitioners, and residents and fellows, because they're dealing with a lot of this stuff. So this is a slide from 2002, right? So let me show you where I went from that. So this is a slide from 2012. So I said, well, we're going to bend this cost curve, right? We're going to bend this curve down to where it's background noise. And I don't know if we've succeeded or not, but we're working diligently at this. Now let me show you a slide from 2022. Okay, this is thanks to John Yoon, our former fellow, and Greg Basil had a role in this. This is, you heard Greg give a talk last year at Grand Rounds talking about stuff like this. This is technology to track granular trends. We're showing that the ability to get someone through a fusion endoscopically, which is in red, versus a microdiscectomy, which is in blue, starts to have a similar fingerprint. Now, that's a very big statement. If you're paying attention and thinking about anything, this is like what happened with endovascular. Right? This is something that may be major. So you look at narcotic usage, you think about narcotic usage on post-op day 1, 2, 3, 4, 5. Well, the blue is my case, is MIST lift, and the orange is the awake fusion. Think about that. And I already told you about the opioid pandemic. This is not trivial. Many of you may know people who died because of overdosing. And we have some role. I don't like people say we create the pandemic, but we have some role in it. There's some minimal role, but if we can minimize the use of narcotics, that's always a good thing. Now, this is cost data. This is really hard to get. I had to wait till the CFO of left to get the data on the way out. I said, listen, you're leaving anyways. Can I get cost data from you? And he's, because he liked me a lot, he says, Mike, I'll give it to you. This is almost impossible to get, this kind of data, right? But it's been published in the Red Journal. And you can see that if you look at my data, this is again, Mike Wang versus Mike Wang, the cost of doing the awake fusion versus the cost of doing an MIST lift is different. We're saving money. We're saving almost about $3,000, right? More per surgery. Now you do that over and over again, that matters to hospitals, right? People wonder why they can't get equipment. Well, maybe you're costing them more than you're worth, right? But I know people like Rick Komatar delivering a phenomenal economic value to UMH. And I mean, honestly, Rick can kind of, I gotta be careful what I say because Alan's on, but Rick wields more economic power than probably anybody on this campus, certainly more than me and more than Dr. Lamelis, because his margins are so huge, not on the professional side, but on the hospital side, right? But this matters. People pay attention to this stuff. Ignacio saying something? Ignacio, you're going to say, don't say that. We're not going to record now, right? But I'm trying to have a real conversation with our trainees because they need to know this. They're going out in the real world. So, Ignacio, do you need to say something? Somebody said something, but okay. Feel free to jump in at any point. So this is another example. This should be compelling to you. This is Mike Wang against Mike Wang again. So the left is an MIS TLIF, the right is an awake TLIF, both done at University of Miami Hospital. And I picked two random cases. I just said, I'm going to pull two cases right now, okay, off of Epic. So this is what's entered by the nurse, by the way. So it's totally objective. It's not my impression. So we're in the room with the MIS TLIF at 7:25. And this is 2 different days, by the way. This is not me, and this is 2 different days of the year. But both cases happen to enter at 7:25 because UMH is like that. Bridget Morgan, shout out to Bridget, does an amazing job for us, right? So we entered the room on both days. This is the Mike Wang version 1, Mike Wang version 2, entering 7:25, okay? So even start, it's like pole position, right? We're both in pole position. Now the prep start for the MIS TLIF, that's pretty good, right? I mean, Jackson, I'm gonna start surgery at probably 11 o'clock today, but probably no A-line, right? Intubation, and they're ready for us. Prep start is 7:32 because the awake fusion, the patient rolls themselves over. So we're 7 minutes in. Now I'm ahead of myself. I'm sorry, my picture's blocking what I'm seeing here on the right. I'm saving 17 minutes here. Now, how about procedure start? So procedure start has to do with when you say, okay, we're ready to cut the skin. Okay, so 8 o'clock for the MIS TLIF, 7:38 for the awake. Okay, that's 22 minutes. Okay, why is that? Well, we're not connecting Bovie. There's no light handles. There's no bipolar, right? There's none of that stuff, right? No monitoring, right? Procedure finish. Okay, so the MIS TLIF takes longer. Now it's almost 11 o'clock, and the awake fusion's done at 8:30. So it was a good day. And then that's 126 minutes ahead. And then you got to get out of the room, right? It's not like when I pull my gown off, like the next case starts. You got to extubate the patient. You got to flip him back over. You got to take the equipment down, right? And out of the room. This is not turnover. Out of the room, 11 versus 8:35. That's 151 minutes. Okay, now I'm going to say a cautionary note. I've heard it said that, oh, Dr. Wang likes to rush through stuff. I do not rush anything. This is not rushing. Because your Ferrari is faster than a Honda Accord, because the airplane and jet is faster than you walking, is not rushing. The 747 or Gulfstream is not rushing. The 747 is faster than you walking. That's a very important point. I'm going to say this again because I do not want the wrong message to get out there, because a lot of residents are not paying attention. They're not listening. They're hearing things that are not real. This is real. Now, 151 minutes saved per case. If you do that 100 times a year, I'm not saying you do it 100 times a year, but I'm just giving a round number. That's 15,100 minutes a year. That's 251 hours per year. That is 10.5 full days per year. Now, I'm not talking about 10.5 working days. I'm talking about 10.5 24-hour days per year. Now, what can you do with that? Well, you could do more surgery. You could see patients. You could spend time with your family. You could be a better person. You could go work out. You could write some papers. You could go interview. You could travel the world. You can do a couple things with 10.5 full days of operating time. That's operative time, OR, in the OR time versus your time, right? I know people are like, well, I can take a vacation anytime I want. Well, guess what? But I do twice as much surgery as you, right? So think about that. And time is the one thing that you talk to billionaires, you're like, if you could buy one thing, what would you buy with your $1 billion? They would say, time. I want time, right? So what if you're not convinced yet? What if you guys are like, that doesn't matter to me. I hate my wife, so I love being at work. I want to be here all day long, every day. Okay, so, or husband, I should say. sexist. So here's what was happening in pandemic. Look at this kind of stuff. This is people pulling people off of each other, right? Hospital employees stealing PPE, right? All these things happening, hand injuries, right? Because people are staying at home doing stuff like cooking that they never did, right? Accidental poisonings from disinfectant. This is real. This is some real stuff that happened the last 2 years, right? And for the first time in history, doctors were making less. Now, doctors make less every year for how much we do, right? But this was like salary cuts. This is Mayo Clinic. We're going to cut your salary. We took cuts here at UM, right? Furloughs. That's the existential crisis in a minor version with COVID, okay? Think about this. How many of you guys just signed a mortgage, right? You ready for a 20% cut? You ready to be evicted, right? What are you ready to endure, right? So this is not unimportant because your assumptions that you have today are probably not going to apply completely in another 20 years. So these are the slides from the White House, okay? Whether you liked or didn't like the last White House or this White House doesn't matter, right? This is not political. These are the slides from the US government, okay, in April of 2020, okay? Now, I know right now everybody's like, well, we're past that. But I want you to just take for a second to think back to the time. Just think back, because I know people block this stuff out. When you were starting a case and everybody ran out of the room and they let the young, usually female, so it's sexist, CRNA intubate the patient while the older anesthesiologist left the room, and then you had to wait outside the room for 7 minutes to clear the air, and then you went back in there. I want you to think back to that time. And I want you to think about what the next crisis is going to be. And I'm not saying it's a virus. It could be all spinal fusion is not allowed. Vaccine for all brain tumors. We just heard great pathology. The whole point of the pathology is to cure the disease, right? Oh yeah. What about better drug treatments, right? There are real crises out there. And this is what was shown. Phase 1 reopening. Elective surgery. Now, I'm going to go another 20 years maybe in my life, maybe not. And you guys will all go through your lives for umpteen years. You will never, I'll bet $1 billion right now. $1 million, I have $1 million. Okay, I'll bet $1 million to anybody listening right now. You will never hear the American president, whoever that might be, talk about elective surgery to the national public. I don't mean to the American Medical Association or the Association of Neurosurgeons. I mean to 340 million Americans in the middle of the day where they block out the TV or soap opera stops, beep, 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 message from the president, elective surgery. If that happens in the next 100 years, I'll give you $1 million. It's never going to happen again, right? That means this is important. The statement was that surgery matters because it works. And you can do it, but only as an outpatient. So people are afraid to come to the hospital. Who knows what the economic effects are going to be? This is going to be the big push to single payer. People say, well, I got privately insured patients or I do work accident stuff. Well, guess what? What if that disappears, right? And the pressure on all of us, and who hasn't heard, well, how are you going to make up for all this that you didn't do during that time? And what parts of this are going to be long lasting? We already know that every university in America said, we don't want our doctors to travel anymore because you guys work more for us if you don't travel. But is that part of the mission? Well, that's what they're saying to us, right? I know they're not saying it explicitly. They don't want us to travel. This is obvious, just stating the obvious, right? So this is where doing MIS surgery really does matter. Is it really MIS or is it just something you're saying to people? So this is, again, Kevin Foley's paper showing that, right? So now the differences matter. Will patients have to stay in-house? Do they need an ICU bed? Is rehab going to be necessary, right? So during the pandemic, I actually looked at the U-chart a little bit more than I do now because we all had a little more time and we were kind of bored. And so this is a lady who'd seen me in February who basically said, well, I can kind of peter along, but like the thing is like, this is getting bad. And she was a young lady. She was in her 50s and she had kids. And I got a message through U-chart saying, I'm going to kill myself. I'm like, wow, I better go look this up, right? So this is what's going on. She goes, the shot stopped working. I can't live with this anymore. But at the time, we're not doing elective surgery, right? So we're going to do elective surgery because we can do it without having the patient stay in-house. And Alan did this and Rick did this. People started to do this, right? We started to be pressured to do things we didn't do before because it was an existential threat. A pressure upon us, right? And so, but there are challenges with this. There are issues with this, right? So I'll show you some of the mistakes. This is an early case we did, right? We broke the end plate lifting. Too much pressure, stress, strain, right? You got to understand physics, stress, strain, right? Because we're relying on indirect decompression. Here we fractured the end plate. That hurt that patient, right? Here's another example. Infection, but not a wound infection. This is when we were trying to figure out what was going on with this stuff. And it turns out that the cleaning process was not proper. People didn't know how to handle this equipment in central sterile. So we had to go down there and say, listen, we got to do some QA, QI on this stuff, right? Look at your results and say, look, what are we going to do with this, right? Look at that infection, right? In the disc space, right? Early cage extrusion, right? This happened immediately, right? And remember this is UCLA VA hospital, right? Dozens of people died there because the staff at the VA did not know how to clean their endoscopes for doing things like, I don't know what you call it, but where you go up the bile ducts and all that. It's complicated. But know your equipment, know your people, know the bottom level people. And when I say bottom, I mean the people that do the grunt work, your MSAs, right? Your central sterile people, know who they are, right? Here's an example of a very, very high level person here who had this problem, needed this opened and cleaned. It's on the fractional curve. And I didn't understand the anatomy as well then. And we got into bleeding anteriorly, right? She did fine, but for about 40 minutes there, I was sitting there trying to figure out what was going on, right? Understand the anatomy, what's going on there, right? And understand and respect it and know your limitations, right? And here's another example. So you can see the cases are indicated, but how do you do them, right? So, here's an example of trying to get around this post-laminectomy spondy, right? Patient has DRG pain, right? Because you can't get around this. It's an impossibility in some people, right? The critical structure is the dorsal root ganglion, right? So you've got to get around the facet joint. So I always tell the residents and fellows, like, you guys are so busy looking at this, why don't you take a look at the facet joint? About 10 years ago, I gave a talk on facets because I love to talk about facets. Facets or zygapophyseal joints are incredibly important to understand. If you don't understand them, you don't understand dorsal surgery. And everybody says this, I'm just going to go through this corridor. So I had the pleasure of editing a textbook on lateral approaches. It's the only one out there besides the XLIF book, which is a Nuvasive book, which is a commercial book. And the introduction and history is written by Luis Pimenta, who invented the XLIF. And he shows this, and this is a very important picture. He shows this in Brazil. He's trying to invent the XLIF, and he's going down the only corridor you cannot go down, okay? You cannot go down this corridor. Every design team, some young surgeon goes, let's use this corridor. Because it makes sense. You can get everywhere from here, right? And you can be prone. You can put the screws in. You don't have to do prone lateral or single position lateral. It's disastrous because you can't do that with a big instrument. But if you get small enough, maybe you could, right? So what's next? There's a lot of stuff coming. What if we were to take the awake part, take it out, and put the robot in? Okay, well, here's an idea, right? Now you get localization, stabilization, pain control, fixation, indirect decompression, and miniaturization. And remember, the robot is not anthropomorphically confined, right? So, there's a certain range of sizes of your hands. But what if you could have 6 hands or 7 hands or 70 hands? What if your hand was 1 millimeter or 1 meter? Think about that for a minute and what the future brings, right? And this is a nice video put together a couple of years ago by Jason Leonakis, and he was an Infold fellow, just showing how we do this robotically. And if you watch this video, what you'll notice is, and there's Ephraim Cox putting in the pin, we're going to spin the O-arm. If you watch this carefully, what you're going to see is what it does is it takes away those pieces that are reliant on my, I'm going to say it's skill set, okay? All those things that I had to learn about how far away from the midline I'm going to make an incision on this patient, about how I'm going to access Camden's triangle. I'm going to take those geographic navigation pieces out of the picture using the robot. And so, of course, here we're going to put the screws in first because we're going to move the patient, right? And you can do it in any sequence you want, but the idea is we're going to put in the screws and we're going to do everything else essentially the same, except we're going to use now neuromonitoring. And Yinda Lee, one of our best fellows, came from Australia. He just published, it's going to be out soon, a paper on the parameters of DRG stimulation, because that's important, right? Because it's not the same. The DRG is not the nerve root as it is traversing as it comes off the fecal sac. And it's a different parameter, right? So we're going to put in the screws. And I want to put in the cage by accessing Camden's triangle. Here we're going to spin again. This is the first robotic case we did. We're going to spin again just to check everything. And then we're going to basically neuromonitor our way through Camden's triangle, right? So that you get the idea that this robot now allows us to have not just guidance, but the platform with which to work. Here's Roberto Perez Roman doing endoscopic drilling. People are like, well, I don't understand the endoscope. Well, part of the thing about the endoscope is you need to have good control of your hand. So Roberto is here drilling with off-the-shelf stuff, drilling the holes that's going to allow him to do interlaminar laminectomy, right? He's going to drill all that stuff out and create space to allow us to get access. And then, and it's an infancy, right? But you can see that it's not just about putting screws in, it's about learning how to be in a place and having stability in terms of the structure. And here's augmented reality. We have augmetics here. And so, this is not a robot, but it's navigation, and this allows us to work together in real time. And, it's an exciting technology, again, also in its early stages. But think about what that means when we're just wearing these big helmets, and that's coming in like a year, and everybody in the room can see stuff, and we can see the x-rays, and think about what that means. I know Timur has been very active in augmented reality, trying to push the envelope. And I know Mike Ivan's done Magic Leap work. And you get the idea, is that the technology can make this so that basically anybody could probably do these kinds of surgeries, right? And we're moving into deformity realm, right? So here's a 3-level awake T-lift done, showing that we can correct these types of very segmental deformities. But we can also add lordosis in the right patient. We can get the cages in and get inner body distraction and get that achieved, right? So I'm sorry, what you guys let me start early, so I promise I'm not just going to keep going. I'm going to come through some of this stuff, right, and try to show you where we actually are headed, right? So we are headed in a very interesting direction, which is different. So this is an example of MIS sagittal correction, right? So here's a patient with severe sagittal deformity, right? And is going to need a correction. But here, instead of doing a T10 to pelvis, we're going to go short. And we're going to do an anterior column resection or anterior column release. And here you show us going to L2-3, right? We're doing inner body cage placement. There's the L2-3. And then we're going to get L4-5 and using angled instruments. And then getting around the crest. And then we're going to go to L3-4 and we're going to do an ACR. Right, so we're going to go in there. We're going to cut the ALL. You can see the knife blade going down, cutting the ALL, protected, and then getting the inner body distraction with expandable cage. In this particular case, this cage expands passively. We don't have to get correction in lateral position. We can go to prone position, put in perk screws, and here you see the massive lordosis being added, and doing that with essentially a 3-level fusion, right? So this is very, very powerful, this type of approach, but it still requires that part of opening up the ALL, and the lateral approach is not entirely benign, okay, even if you're really good at it. So where are we headed? What if you can do that endoscopically, right? What if you can do that, right? So here's a paper from Roberto and Greg and Vignesh, right? They're talking about ALL release with the endoscope. And Roberto was good enough that he actually did the slides here and took the pictures and all that. And, basically was able to get the idea going, right, of sectioning the ALL with the Kerrison safely with, as Christoph Hofstadter would say, the third hand pushing critical structures away. And what if you could do this without general, right? And what if you could stage this? So I like to say, those of you have been in clinic with me know, if I see a dentist, I love it. I walk in the room, I say, hey, listen, we got a lot in common, man. There's 32 or so teeth, and there's 32 or so discs. And everybody hates us, but they need us. And they're all clamoring to get into us, but they're terrified of us, right? And we worry about bone healing, and we use BMP because they use BMP too, right? Think about trying to get tooth to heal when you're chewing, you can't brace the tooth, right? And think about what an orthodontist does. Some of you have kids now, some of you had braces, right? I'll tell you what they don't do, okay? You don't walk into an orthodontist and say, okay, perfect, we're gonna straighten your teeth, sit down in this chair, they take a hammer out and smash your teeth out. 32 teeth coming out, right? Then they drill holes and implant perfect 32 teeth and it looks beautiful, right? That's kind of what we're doing in surgery today. What if we did what they did? What they do is they say, okay, well, let's make a plan. Then they put on some braces and they adjust and they let the teeth move. And then they see you next month and they say, okay, well, it looks like this is going like this and that's going like that. And let's tweak the plan a little bit. And we don't know exactly when the braces need to come off, but we're going to think it's this range, right? That's how orthodontists work. What if you could do 6 surgeries instead of 1? Today, we're going to do a front back neck. It's a big deal. It's one of the Jackson doctor's aunts or something like that. And it's going to be a lot of surgery and there's going to be issues. What if we did that surgery over 6 surgeries, 6 little tiny surgeries? And so here again, Greg Basil, you see, Greg Basil writing about modularized systems in world neurosurgery. This is cervical, right? But what if we fix someone's deformity over 6 months? That would be the beginning of something truly transformational that would allow us to dodge the next meteorite that will probably something like wipe out spine surgery as we know it. And that's what we're headed to. And that's where I'm indebted to my partners and my bosses and my mentors, people like Michael Puzo. Obviously, Alan trained me. Barth set up the environment where I could succeed here locally, so I thank him greatly for that. This is where we're headed. I don't know if I'll get there. I don't think I will. I think guys like Greg, Jason, and James, and Vignesh, Roberto, Aria, Christian, all the people who are looking at this seriously, and our fellows, right, are the ones who are going to carve this out if they're given the opportunity. I hope they have an opportunity the way I did here in Miami. I hope they find their little niche. So as a little mammal, you can grow into the future Homo sapiens. So thank you again for your time. Thank you for listening. Thank you for all of you who came on the podcast. We passed 360,000 listens. So we're super excited about that. And I will stop sharing my screen at this point.
Hey, Mike, as always, a full, phenomenal talk. I was going to ask you a philosophical question, and I thought you were going there, but I thought you were going there, but you never did. And when I've raised these questions before, people don't like to talk about it. But I've gone, from everything really big to somewhat small, but not microscopic, like you're talking about, not through a needle. And I probably won't, just because, that's my stage of my career. I probably won't ever get there. But I worry that the smaller we go, the more we look like an anesthesiologist or a pain doctor. And I really, really worry about how that interference is going to look like in the next 2
Yeah, Alan, that is a fantastic point, because it's
days
very
for
easy.
surgery.
Right, that's a great point, because the idea is technology is powerful, right? So the anesthesiologists are like, well, I can do fusion now, so I'm going to do fusions and make more money doing that. And you're right, it's wrong. We're not, you've experienced this over the last 2 years personally, we're not in a position to police other doctors. I think the only way we can do it, and neurosurgeons have been good at it, is Bobby's on, right? Eric might be on. How do we keep a foothold in endovascular, even though there's so many more neurologists? Well, I think we do it by being better. And so if we do a better job than anesthesiologists, then the really good anesthesiologists may come to our side, and it will hopefully scare off the bad ones. But I don't know. I really don't know if that's the answer. I see Kathy Rosenberg and Ruth Perez are on this call. I think that having teams of people around you are the key to this. And we are not in a position to police that. I worry about that, as you do. It is a real fear, and it is happening every day with Vertiflex and what is the mini decompression? I'm blanking on it right now. Anyways, everybody knows what we're talking about, right? Those type procedures. Great point, as always.
Dr. Wang, a little question on the outside. How do you manage the DRG syndrome?
So I don't have it anymore. It's the early cases, because I would, I'll tell you how this happens, and I want the people to hear it, because a lot of people come here to learn endoscopy. When I first started seeing DRG problems, I would go to the German surgeons, and I would say, "Hey, listen, what are you doing about this?" And they all laughed. They're like, I'm like, "What are you laughing about?" They're like, "We see this all the time." The surgeon starts endoscopy. They actually like it, because not everybody adopts, right? And they do about 20 cases, and they start to say, "Wow, if I could just drop my hand, I can get in the canal." And then they get it. And I'm like, "Well, why don't you teach them otherwise?" And they're like, "Well, we're not interested in that." So the answer, Timur, is that it usually goes away. But now we have DRG stimulation. And I haven't used it yet, because I haven't had DRG problems lately. But DRG stimulation is super powerful. It is maybe the biggest thing that's happened in pain management, I think, in spine in the past 15 years. Great. We got to finish a little early. Sorry to run a little bit over. Thank you again. You guys, enjoy your day.